Thank you, Sue, and thank you to people here and those online, and hopefully we'll romp through my 37 slides in 20 minutes. I really will try to keep the time. Okay, oh, and I've got a timer, that's even better. Perfect. Okay, so is patient safety working? Yeah, I mean, the latest Embrace reports do show that stillbirths are down, neonatal deaths are down, and some inequalities are improving. And no. So when we look at the stillbirth rates as it's been falling over time, you can see from this graph that the decrease starts around about 2009, something like that. So before all the initiatives that we currently have, the stillbirth rate was going down steadily. The uptick is around COVID. So it's beginning to come back down. It's down now more or less where it was before COVID, but the trajectory has been there for some time. So the question is, it is going down, but why is it going down, and what can we learn from that? So the latest Embrace report did, first of all, one of the things to remember on stillbirth is that 76% of stillborn babies are premature. So the things that we do in pregnancy might help that, but the things we do in labour won't be making much difference to those premature babies. So of the others, if we look at stillbirth at term, the change in stillbirth at term between 2019, so just prior to the pandemic, and 2023, is basically a reduction of about 17 per 100,000 babies. So about another 102 less babies, which is fantastic for the families of those babies. You know, it's really important that we are achieving this with whatever we're doing. We don't quite know why, but we are achieving that. But that still means that 592 babies are still dying every year. So all the things we're doing, all the effort we're putting in, all the procedures everybody's engaging in might be having some difference, but there's still a very long way to go. And the question is, can we keep doing more of the same, or should we be thinking about doing something else, really, now, or something additional? And then when we look at the neonatal situation, it's the same kind of thing. If we look at term, so basically it's been reduced by 4 per 100,000, or 24 fewer a year, and there's still 360 babies dying. There is an improvement in equity, so the inequity margins are narrowing in some cases, but inequity is still there, and in other cases, as you can see, in the neonatal deaths, they're going up still. Oops, let's go back. There we go. And this is a graph which doesn't actually have the UK on it. Interestingly, quite a lot of international comparisons, for some reasons, do not have data from England on them. Sometimes it has Scotland and Northern Ireland, very often not England, and I don't really understand why that is. But if we look at this one here, this is neonatal mortality comparing a range of countries from Chile at the top, Japan at the bottom, and looking at the percentages, changes, percent of neonatal mortality. So ours was effectively 16% in 2021, which is the comparison year here. And I don't know how clearly you can see this, but if my pointy thing works, which it does, hooray. So the 16% is kind of here. So basically all these countries have a better neonatal mortality than we do, and many of them have much lower cesarean section rates than we do of interest. So this is a slide looking at and it's a very busy slide, apologies for that. It's looking at the changes in cesarean section rates across a range of countries. And I know you can't see because it's very difficult to see the black on the white, but if we compare Sweden here, section rate of 17%, with a much lower perinatal mortality rate, and ours is showing here at, I don't even read it myself, 32%, something like that, 32% when this was done. It's now 45%, our section rate, if you didn't know. So we are, compared to Europe, our section rates are going up much more highly. So this is Northern Ireland and Scotland data, but same really for England. Double that of Sweden in 2019, and as I say, 45% in England now. So whatever correlation there is, and there may be some between caesarean section and lowering baby deaths, which obviously is a good thing, it's not, there's a lot, we're doing a lot more than we need to for the benefit that we're getting, put it that way. And maternal mortality, of course, is rising in the UK, at least on the last Embrace report, which was a year or so ago, and much higher than other countries. So again, this is a comparison to Sweden. So ours is 12.67, so it's somewhere up here, around Chile and Costa Rica, and all these other countries are much lower. Sweden is 4.8, with a caesarean section rate of about 17, might be 20% now. And we've heard about birth trauma very eloquently this morning, so I don't need to tell you any more about that, and this is a very good report, and I hope people have read it. It's very important. And litigation is going up. So we're not reducing litigation by doing all these in the interventions that we're doing. And it's more expensive. And of course, this famous graph up here, this is the cost of litigation, and this is the cost of maternity services. So we're spending so much more on paying out for harms than we are spending on the service itself. And that isn't getting better. Now, just a little caveat to that. Obviously, historical payouts, so up to 21 years, you can sue. So some of this data may be about historical payouts that are still coming to the system. So it's not necessarily clear that these are new claims going up, but we still aren't managing generally to reduce the litigation costs with what we're doing. So, are the tools we're using working? That's the first question. So we have a number of tools in the toolkit. I'm not going to look at all of them, and it's likely that some of them are working some of the time for some cases, and that's really important. But this is a 2025 paper that actually looked at comparing maternity unit ratings from CQC and outcomes. No association between CQC ratings and outcomes. So the paper, the authors say, concerted action is urgently needed to improve the inspection-informed ratings of maternity services because it is not linked to outcome. Then there's a question of ultrasound, which again we use an awful lot. It's very helpful, very useful in many ways, but again it has its limitations. So this is a report from the Big Baby study. I don't know if you know, the Big Baby study results are now out. I'm going to say a bit more about that in a minute. I assume you will know this is offering induction to women at 38 weeks gestation if they were diagnosed with a big baby using both the GROW measurement and ultrasound scans, to either randomised to immediate induction or expectant management. And 42% in the induction group and 40% in the standard group actually had a big baby. So basically, 6 in 10 women diagnosed with a big baby did not have a big baby when they actually had in this study. So basically, very few weighed more than over 4 kilos, which raises a whole load of questions. Do we have the right tools to be diagnostically accurate? That's worse than flipping a coin. So do we have the right tools to be diagnostically accurate about the things we offer to women? We all know about routine fetal monitoring. We all know the conclusion from that although it reduces neonatal seizures, it doesn't actually make a difference to long-term outcome. It does increase cesarean section, and it does increase instrumental birth. We've known this for years, yet we're still doing continuous EFM. And then we ask the question, what do women want? Well, this is a study that we did for the World Health Organization, looking at all data from all countries and all languages all around the world, qualitatively, and it influenced their guidelines quite profoundly. And we found these things, which won't be a surprise to anybody here or any service users, I think. Giving birth to a healthy baby in a psychologically safe environment, practical and emotional support, competent, reassuring and kind staff. Most women in most countries around the world would prefer a physiological labour and birth if they can have it, though they acknowledged that there was a need to go with the flow, and if they did need intervention or if they wanted intervention, like a planned section, then they wanted a sense of personal control and decision making. None of this is a surprise to any of us. That's what women want. That's what's in all our reports. Are they getting what they want? No, they're not. So babies are still dying, but you can see the list here. You know, the things, already you've heard about continuity more than once today, you know, about what women want and what women ask for, and they are not getting it by and large. CQC report, this is 2023-24, and they looked at the experiences for different groups of women. And what I find interesting about this is what's not there. So they say women had poor experiences of care if they had an emergency section. I'm looking at mode of birth here, there are other things in there. Assisted vaginal delivery or a planned cesarean. So what did they have a better experience of birth for then? A safe, positive physiological labour and birth, arguably. But many are not getting that. And on the other hand, we could say, well, why aren't these women with these other experiences not having good experiences? Because they should be. Just because you have an assisted vaginal birth or you have a cesarean, you shouldn't have a worse experience. So I think it's raising a whole range of different points. And of course, there's the constant issue about ethnicity as well coming into play here, which, you know, again, we all know about and need to pay attention to. So I want to come back to this safe, positive, spontaneous labour and birth question here. This is a US activist posting online, natural birth traumatised me. So it was, you know, horrific, excruciating, traumatic. Much like my first two, my third child was induced. Now, natural birth and induction. And I think that's a very interesting conversation to be had there about how women are beginning to conceptualize what is a natural birth, and then how they're becoming fearful of this thing that they think is what natural birth is. And I think that's something for us to reflect on a bit. Because it can create negative feedback loops. Now, I was really surprised. I went on the NHS choices, I think it's planned place of birth or place of birth, NHS place of birth, I think it is. I typed into Google. And this is what came up. There were a whole range of things. So it started with, you can have a spontaneous birth in a hospital, you can have a planned cesarean, da-da-da. And then if you're thinking about an unassisted birth, that's also fine. So here's some stuff about unassisted birth, free birth. Says nothing about the risks, nothing about any of the issues around that. It's just like, yeah, that's a choice like any other choice. So we kind of end up with this cycle where we're saying, okay, there's a reduction in safe, positive options for women. There's an increase in fear and trauma. They therefore make a choice for planned cesarean or for a free birth because actually the other choices don't seem to be available to them. Then you get less options, and we know that home births are becoming more difficult for people to get. The home birth services are closing down, birth centres are decreasing, so the options actually aren't there anyway. And then the whole thing goes around a circle. So we seem to be stuck in this kind of loop, which is very problematic for staff and for service users. And then there's a question about technical solutions being the default. So here is another, these are the two papers out of the Big Baby study. So one is the data paper here in the Lancet, and the other is the cost effectiveness paper. And this is what they found. So no difference in adverse outcomes for the randomized groups. As we've already said, diagnosis of Big Baby inaccurate. The health economics authors said what you can see here. It's not a cost-effective approach. So basically they're saying it's not cost effective to do an early induction to reduce cesarean, to reduce shoulder dystocia for women with diagnosed big babies, not least because it's inaccurate, the diagnosis. So maybe we should do planned cesareans instead. And I'm like, well, there was another option here, which was expectant management. Why would you not be saying that that's okay, really? I can't understand it. And I know some of these authors, and they're really good. So they said, clinicians can be reassured a decision for earlier delivery is a viable option. Well, what about a decision for expectant management is a viable option? Is that not equally viable, given the outcome? Some of this is based on what they call a per protocol analysis. So they looked at people who actually had what they were randomized to. But even so, the reason that one of the reasons why it was equally as expensive, as you can see, one of the reasons for the cost-benefit analysis conclusion was because induction increased neonatal care costs. So why would you recommend something which increases costs because you're having more neonatal care? I have to say I don't get it. I really don't get it. But I think it's partly because we have got to the point where that is the norm. And expectant management or support for safe physiological labour and birth is seen as deviant, I think. I mean, I'm making a strong case. And I know this is not true in every unit, and I know it's not true for every practitioner. But I think there's something out there in the zeitgeist that we might have to be paying a bit of attention to. So this is a document from the RCOG, who produced a lot of very good documents. So again, I'm not criticising the RCOG here. I'm just making a statement about where our thinking is. So in this case, this is advice for staff to use with women who are planning caesarean section. Planning caesarean section. So in this thing, it says, women planning a vaginal birth should be informed of their risk of an instrumental or caesarean section. So this is not women planning a caesarean section. This is women planning a vaginal birth. And it goes on to say that basically they could have a risk of 1 in 2 assisted vaginal birth and 1 in 3 emergency caesarean section. So any woman hearing that, they're going to go, well, I'm not going to go for a vaginal birth. Why would I? Whereas if you look at NICE, they say that if women have their babies out of hospital, their chance of a spontaneous birth is 77% for low-risk Paris women, and much more for multips, obviously. And risk of an emergency caesarean section is really low. So the problem is, if you aggregate all the data from women labouring largely in hospital, maybe you do get the data that the RCOG are talking about, but you don't get that if you offer women different options. And if you're not offering them those options cease to be, and they don't get the option, having that option. So, again, it's a kind of space we're in, which I think we need to be thinking about challenging. So there's a risk of overdiagnosis. So we do have some gains, which I've already talked about, but we also have some losses. And overdiagnosis, this is a BMJ paper, nothing to do with maternity, does raise a whole load of risks for people that are experiencing interventions that they don't need or don't want. to create a small benefit when in fact we could get maybe a larger benefit from a different process. And there are opportunity costs. So obviously, if you're doing those things, then you're not doing other things. And if you've got loads of women being induced, for example, who have really, really low risk, you might miss the one woman who really does need to be induced because women are waiting 4 days to be induced, and therefore you increase the potential for harm. And of course, there are consequences for staff, some of which we've heard about. So how about changing the conversation then? Well, I think we should invest in precision. I do agree that what we were looking at in terms of genomics is really interesting. I think we do have to be careful about the psychological consequences. But if we can actually really get ourselves to really be much more precise about who is at risk, we've got a much better chance of succeeding in the future. There's also making sure that systems have more precision. This is from the East Kent report, separating signal from noise. And I think we could really do some things with that report. And likewise, in terms of compassion, which has already been raised, in the East Kent report, compassion was raised as a really important issue. In this case, compassion towards the service users, but also, as we've heard this morning in that great presentation, about compassion towards staff when things go wrong and staff are traumatised. Again, this is from the birth trauma report. So individuality, choice and care, all the things we hear about all the time, but they're not happening. And this, I think, is quite interesting here. This was a study done in a paediatric outpatient clinic where they basically, a dental clinic, that's right, they randomised parents who were there with their kids to watching videos of kind things happening, nice things happening, or videos of kids' cartoons. And among other things, they found a significant increase in those who, this is only while they were waiting to go into their clinic appointment, in people feeling inspired, moved or touched, happy, grateful, etc., and less anxious if they watched the kindness stuff. And also, each group was given the option to have, they were given an honorarium, they were given the option of keeping it or donating it. And those who watched the kindness videos were much more likely to donate their honorarium just by watching kindness happen. So just doing kindness, small acts of kindness can make a huge difference, generally speaking. In terms of systems, I think we can move from this notion of safety 1, only looking at when things go wrong, to safety 2, which is also looking at when things go right. And that is beginning to become a much more prevalent approach these days. And one of the tenets of that is things don't go well because people follow the procedures all the time. They go well because actually people adapt and they do what works in their context. So it's actually about guidelines being flexible, in place, and acknowledging expert people's expertise in their practice. Having a deep and broad concept of safety. So again, this is back to the safety 1, safety 2 idea. Oh, and we're doing a study actually, a beacon site study, which is based on these, led by Claire Feely, based on these 4 principles: optimal outcomes, service user well-being, staff well-being, and optimal use of resources. Psychological safety. So basically this idea of moving from trauma to joy. So this is a study done by Jill Thompson, and she looked at women who had a traumatic birth, and they used words like horror, rape, abuse, fear, terror, hell. And then she looked at them when they had a positive birth in the next pregnancy, and you can see the words here. They're far more than satisfaction. There's something much, much, much beyond just being satisfied. And achieving this, if we can, is critical. And this is just another similar quote, I think, it's from the same, one's from the same study, the other one's actually from Dennis Walsh's PhD, I think. It's about the long-lasting effect some of these things can have. So finally, in terms of my list, and then I've just got a couple of finishing slides, enable staff to do the job they want to do. So many people say, including midwives, they're leaving the profession because they can't do the job they want to do for all kinds of reasons, including bureaucracy and some of the things that have been discussed already. And in our study during the COVID pandemic, we came up with 10 things that we thought would make care sustainable in the future, and you can read them there. And we really believe that if we can get those things right, then we can actually make a difference going forward for everybody. So I want to just give a couple of examples of where things are going really well. One is the Hamler service in Leeds, where they are doing continuity with marginalised groups of women. And they found 2 things that were really important, and they were both based on relationships. So what they call adaptive network activation, linking women up across networks and building trust through relationships, which I think we'd all agree is a good thing. And this is a quote from, these are some quotes from there. I'm going to put them up quite quickly just because of time. We've got half a minute.
You can have a bit longer, Sue.
I can have another minute, can I? Yeah. It blows my mind it's not standardised care. And it really works. We've got great outcomes. This is actually local. This is in Derby, where Claire Wood did her PhD, and part of what she did is ask the staff on the labour ward, what is it, maybe somebody here, is there anybody here from Derby, by the way? No. Anyway, what it is that makes you feel good at work. And then they built on that by creating these colleague support volunteers. So just people who've just recently retired, who understand the ward, could be housekeepers or midwives or anybody else, understand the ward, understand the service, and they're there to bring tea, take cake, to run around and take samples, to answer the phone if people can't answer the phone. They're just there to support staff, to make staff feel like they're loved and cared for and looked after. They're there as a listening ear, these kinds of things. And it's been a wonderful service. And if you're interested, you can contact Claire. We now want to make this into a research project to see if we can make it work in other hospitals. So if anybody's interested, please contact me about that. And then finally, just a few, well, I think this is actually my final slide. So, to have optimal care. Maybe we should be applying this to all of our techniques, to all of our processes, to all of our guidelines. Ooh, goodness me, that doesn't fit on there, does it? That's very weird. Anyway, basically what it says is making sure the results of all these things we do, governance and everything else, takes the criteria in the broadest sense for both and. Basically, does it benefit all, not just some, but all women, babies, families and staff going forward? And I think if we can work with that, that would be great. And I think in terms of the one takeaway message, just the small acts of kindness stuff, just tiny things that can be done when you're, I know it's difficult when you're exhausted on a shift, but tiny things that can be done to people. Just even saying to somebody, you did a really good job. If you see someone doing a good job, this was a project that was run up in the north of the country some time ago. If you see someone doing a good job, just take the time to say, you did a great job there, and this is why you did a good job. It takes you 2 minutes, and it makes them feel fantastic, it makes you feel fantastic, and it provides some way of taking this process forward at the very micro level as well as at the macro level, hopefully. Thank you.